I'm not going to dwell very long in saying that, their ammonia is still, we believe, at the end of this 3 days, at the center of hepatic encephalopathy. It remains a very important complication, and this is a very early piece of work that I did together with Stephen, where we reviewed nearly 100, 200 papers in order to pull out what the levels of ammonia were. And as you can see, there isn't a direct correlation, but seems that there is a stepwise progression. I'm not going to dwell about this. So where did the story start? I think this is work of Mick Doitz, Roger Butterworth, Stephen Older-Darming, the Maastricht group, and some of the early studies that we did. And the story is really around this, which Mick concluded yesterday, so I'm not going to talk a lot more about. It was also mentioned by Professor Butterworth, just to say that in patients who've got liver failure, there's an alternative cycle that is operative. That is, the muscle, the kidneys, muscle and the kidneys in particular become very important in ammonia metabolism, and the ornithine phenylacetate discovery was really based around trying to use this story. So the idea really was this, that arose from our initial studies with ornithine phenylacetate, and ornithine aspartate, which is what led us to start thinking about phenylacetate. And what this is an editorial that I wrote to the Subrat Acharya paper, which sort of tells us why ornithine phenylacetate might work in the next slide. So here, just bear with me. So we think that ornithine is the active component here. It is picked up by the muscle. It makes glutamate. You make glutamine in the muscle, and this glutamine recirculates to the gut, where it meets glutaminase and regenerates ammonia. So experimentally, that is what we found in patients that we treated with relatively large doses of L-ornithine aspartate. So therefore there is this recycling. So you take up ammonia on one side and regenerate ammonia. So the idea was really to see whether there is something else that we can do. So this was the hypothesis, that is, ornithine is taken up by the muscle, which Roger Butterworth and Chris Rose had shown that is associated with in the muscle, the glutamine synthetase activity is increased. It will make muscle glutamine, and this, as I've shown you, will regenerate ammonia through glutamine here. And so we added phenylacetate, which you know is a drug which has been used for the last 25, 30 years to treat urea cycle enzyme disorders. Basically, this is a drug that binds glutamine in an enzymatic fashion. And this can lead to the generation of a compound called phenylacetyl glutamine, which can be excreted in the urine. So what you did was to capture ammonia here into glutamine and then take glutamine out as phenylacetyl glutamine in the urine. So that was the hypothesis. And the first studies that we did was really together at the Roe Free. And this is a paradigm that I'm going to describe to you, some studies in acute liver failure and some in cirrhosis. So this is the first study that we did, and I'm sure some of you have seen this data nearly 5 years ago. So what we studied was bile duct ligated animals who treated with ornithine phenylacetate for 3 days, 5 days, or 10 days. As you can see, these are animals with BDL who have been given additional ammonia. There's significant reduction in plasma ammonia, which is associated with a significant reduction in brain water. And this is what the story started around. And we were able to show in that study that there is excretion of phenylacetyl glutamine, as you can see in this model, which was not confirmed in another study from Denmark. But in this model, we showed that there is an increase in phenylacetyl glutamine, which was provided as a proof of concept that this approach may do what it is that we thought, what we saw. What was also very interesting in the study, which we published later, was that this approach had a very marked effect on hepatic inflammation and brain inflammation. So here we're looking at TNF plasma, high values in BDL animals, which is reduced very significantly, and the same thing is happening in the brain, suggesting that there may be more pleiotropic effects of this. A work done by Bala Subramaniam, who showed you some data yesterday, also showed that iNOS activity in the brain is reduced, which is associated with reduction in NF-kappa B activity. in addition to the reduction in the plasma ammonia. But obviously the hypothesis was that this drug would be acting on the liver, on the kidney and in the muscle rather than on the liver. So we established a collaboration with the guys in Tromsø, particularly Lars Ytterbo, in a study that we developed at a consortium in the meeting in Amsterdam several years ago to start to study this phenomenon. Chris Rose was involved with that study as well. So what they have is a model which is of anhepatic acute liver failure animals. And the first study that we did was in this anhepatic model, which is a really relatively short model, that we induced acute liver failure using this model. As you can see, the arterial ammonia goes up. The first experiment was to treat them with ornithine alone or phenylacetate alone. What we found was there's no significant difference in ammonia levels between these three groups, suggesting that there was no additional effect of these interventions. So, and then we went on in this model to study the role of potential ornithine phenylacetate. And we started, so we administered in this study ornithine intravenously. We didn't have a better drug, so we gave phenylbutyrate intragastrically, and we can talk about this if you want. So as you can see, the sham animals have a very high arterial ammonia. Here are the ALF animals, sorry, very low ammonia. Here are the ALF animals, very high ammonia. And if you treat them with this drug, what we showed was a significant reduction in arterial ammonia concentration. But of course, the proof of the pudding really lies in the intracranial pressure. And here are your sham animals, normal intracranial pressure. Here are your ALF animals, very marked increase in intracranial pressure. And if you dial back to what Alistair was saying earlier, the clinically significant intracranial hypertension is around 20 millimeters of mercury. If you treat them with OP, what we were really impressed to see was a very marked reduction in intracranial pressure. And what was really interesting was that these values were not significantly different from each other, suggesting that you almost normalized intracranial pressure in these animals. So I missed out one slide here. So we looked at the urine phenylacetyl glutamine, and we were very underwhelmed with the amount of phenylacetyl glutamine that we saw. It was in small micromolar concentrations where we should have expected millimolar concentrations of phenylacetyl glutamine. So this is a study that was presented yesterday by Runa, for which he has won the prize here, who described a new pathway for ammonia metabolism, which involves glycine. And I'm not going to repeat that study, but as you can see, what he was able to observe was in the urine of animals treated with OP in the same model, the same study, there's a massive increase in phenylacetyl glycine, which is possibly an alternative conjugation pathway. And I'm happy to say that yesterday this paper was accepted for publication in AMJ Phys, so should be available very soon. So because we had not seen the effect on phenylacetyl glutamine, we were looking for additional measures of why this may be active. So we went on to look at the activity expression of glutamine synthetase and glutaminase in our animal models, and we collected, all the organs from these animals. And I'm not going to dwell. It's a large study which is published in JHEP earlier this year. What we were able to show was that there is a significant alteration of activity of glutamine synthetase, mainly in the liver and muscle, and a reduction in the activity of glutaminase, mainly in the gut, which contributes to, we think, this impressive reduction in ammonia. So we now got 3 or 4 things going on with this drug. We have reduced ammonia concentration, possibly as a result of increased glutamine synthetase activity, reduction of glutaminase activity, increased formation of glutamine, and removal of this glutamine by phenylacetate. So that's what I think will work out to new mechanisms in the future. So as Dr. Oria enters, here is his study. So Juan was always very critical of a lot of the things that I did. And he said to me that, look, all this is great, you reduce brain water and so on, what about function? And so therefore, this is a new model that Mark had set up at the time, which is neurophysiological recording every 2 hours for 8 hours after administration of a simulated bleed, if you like, in a portocable shunted animal. And again, this study is published, and you can see that animals treated with OP had significantly better neurological performance using MEP amplitude following this gastrointestinal bleed, suggesting that this reduction in brain water, reduction in ammonia, is contributing possibly to an improvement of mental function in these animals. So as you know, one of the big areas of research in my group is really around ACLF. And the question here is as to whether in a bile duct ligated animal that we induce ACLF in, can we prevent this happening by giving ornithine phenylacetate. Here's the design of the study. Treatment of animals, so the 4-week bile duct ligated rats, treatment with LOP for 3 days. So we studied additionally infliximab, as you know, which some of you have studied before, treatment with saline. We give them LPS here, sacrifice as coma stages, and collect stuff. What was impressive was that so if you give LPS to a bile duct ligated animal, you have a significant increase in brain TNF compared with bile duct ligated animal alone. But if you treat them with OP prior to the administration of LPS, you can prevent that happening to the same extent as you do with anti-TNF without any other additional effect. This, of course, is associated with reduction in brain water, which is impressive, and I don't have time to go into this, but the paper is published, so we showed that there is time to the development of coma was reduced in the animals pre-treated with OP, suggesting that it may be useful to prevent episodes. So here is the sort of the working hypothesis of what's going on. We think in brain failure, inflammation, hyperimmunity plays a role. Astrocytic swelling, which we've shown before, activation of transcription factors with NF-kappa B, we've shown cytokines in the brain, oxidative stress. We think that ornithine phenylacetate, certainly in the animal models that we have studied, affects all these pathways. So therefore, it has potential indications in acute liver failure, chronic liver failure with MHE, and possibly for the prevention of acute on chronic liver failure. So this is sort of the package that we talked to Sera Therapeutics with, and from then on, most of the development had been in their hands, so I can only talk to you about the limited information that I have. So it's a new chemical entity now, which is formulated as a sterile product. So it's an IV form of the drug. It's been diluted to 50 milligrams per mil. Preclinical toxicology, CMC dossier. It's an IND, has been approved for the last 4 years. It has an orphan drug regulatory fast track for treatment of hyperammonemia and resultant hepatic encephalopathy. There are several studies that have been done with this drug to look at safety, and so it's had SAD/MADs done and PK and stuff like that. And really, what all this adds up to is that the side effect profile of the drug is not necessarily a problem both in volunteers and in cirrhotics if you operate between the 10 to the 40 gram per 24-hour range, which is where we think the treatment is going to be. It's probably going to be more in the 3 to 10 gram range, we think, as we move forward. But it seems to be pretty safe, and FDA are happy with it. So this is just to show you some of the data that I've not seen the full paper, I've not seen the full data. This I've extracted from the abstract that was presented previously. 10 gram infusion over 24 hours, or 10 gram infusion over 4 hours, showing that there is a substantial recovery of what you put in the urine, as you can 5.9 grams, which, and again, so despite my rudimentary calculation, I think we're missing about 10 to 15%, which may well be appearing in phenylacetate glycine, which has not been measured in these samples yet. So interesting. So we've got now the proof of concept that you put it in, it will get to where you want it to. So this is the only published clinical study with this drug, and this is done by the late Juan Cordova, who who I've got the pictures of the first patient that he treated with this drug in his hospital. And the idea is an open label dose escalated single cohort study in patients presenting with upper GI bleed who obviously are hyperammonemic. Small number of patients. We administered 10 grams over 24 hours of OP. So here is the data, which I think is very interesting. So here are all the patients. It's an open label study, so as you can see, there's a reduction in ammonia over a 5-day period in all these patients with upper GI bleeding, which is associated with a significant increase in phenylacetate glutamine content up to 2 millimolar, 20 micromoles per liter, so to 20,000 20,000 micromoles per liter. So it looks as if what you're putting in is nearly being recovered at phenylacetate glutamine in the urine. So with this, Mr. Chairman, I would conclude by saying that I think it's very clear that OP reduces ammonia successfully in several models and in an open, in a dose, in a small study in humans. It reduces systemic and brain inflammation in animals that we have studied. Clinical effectiveness in animal models has been demonstrated in acute liver failure, cirrhosis and minimal HE, and in the prevention of occurrence of acute on chronic liver failure. The regulatory strategy, I think, has been defined. PK data and proof of concept is available, and there are several ongoing clinical trials. So the acute liver failure group in the US is doing a phase 2A study, I think. There are 2 cirrhosis studies. There is a 2B study which is going on to follow up on the initial observations that Juan made in his first study in Valdehebron in Barcelona. And there is an Acera-sponsored large multi-center study which is going to randomize, I think, about 150 patients with acute HE. So hopefully when we meet again in 2 years, we'll have some real clinical data to show, to determine the efficacy of this agent. So it's back to the same slide, and you know, I can't thank the people who have given the time to do all the experiments that I've described. A special word of thanks to Stephen and to Mick, who helped me develop the concept around this, and Lars and Chris, who did the large animal experiments in Norway. Thank you.